Long before written medicine, people still lived with injuries and illness. A fall onto stone, a blow in a fight, a hunting accident. Head wounds happened, and some survivors changed afterward. They shook without warning. They lost speech. They slipped into confusion, then returned, then slipped again. To a small community, that kind of suffering looked mysterious and urgent. The head held the problem, so the head became the focus of action. The simplest explanation was pressure trapped inside the skull, even if no one used that word. When someone worsened after a hit, or when headaches never stopped, doing nothing meant watching them fade. Trying something meant risk, but it also meant hope. Over time, a drastic idea took shape. Open the skull on purpose, not to kill, to release, to relieve, to change whatever seemed locked inside. It sounded impossible until bones began to tell the story. Archaeologists later found human skulls with neat openings that did not match the chaos of battle damage. The holes appeared in careful places, with edges that looked worked, not shattered. Some skulls even showed more than one opening, as if the act was repeated and remembered. These were not random breaks from decay or violence. They looked deliberate. And that single, hard clue pushed the question into the open. Why would anyone cut into a living skull? The earliest confirmed trepanations came from very old burials, where skulls carried openings that did not match the chaos of a blow. A crack from violence usually ran in lines and splintered outward. These holes looked controlled, their edges stayed rounded, not shattered, and they appeared in places where a strike was less likely. That pattern pushed archaeologists from suspicion to cautious certainty. Certainty depended on how bone failed. Nature chipped bone randomly, and decay gnawed it unevenly. Intent left a different signature. Scraping left, fine. Parallel striations, like repeated strokes that slowly wore the surface down. Drilling left circular walls and tiny step-like ridges. The shape mattered too. Many openings stayed oval or neatly rounded, shaped by a hand that stopped and started on purpose. Context sealed the case. These skulls turned up inside formal graves, treated like bodies meant to be remembered, not discarded after an accident. Sometimes the removed piece of bone lay nearby, placed rather than scattered. Sometimes several people in the same cemetery carried similar openings, as if a known practice had spread through a community. With tool marks, clean geometry, and burial setting aligned, trepanation shifted from possibility to diagnosis. Once archaeologists started looking closely, one surprise kept returning. The holes did not all come from the same action. Some skulls showed wide, shallow openings with smooth, even walls, as if the surface had been worn down little by little. That pattern pointed to scraping, repeated strokes that slowly thinned the bone until it gave way. It left a signature that looked controlled, not accidental. Other skulls told a different story. Instead of a broad worn area, they carried a tight ring of fine lines, like a track cut again and again in the same circle. That matched grooving, where a tool carved a channel until a disc of bone could be lifted out. In some cases, the marks turned into small pits arranged around an opening. That suggested drilling, one hole at a time, then linking them. Then there were openings with straighter edges and corners, where the bone looked sliced rather than worn or pecked. Those traces fit cutting, with a sharper blade used to shape a window through the skull. Put together, these patterns changed the whole idea. Trepanation did not mean one procedure. It meant a set of methods, shifting with the tools people had and the skill they built over time. The next question sounded simple, but it decided everything. Did the person live after the hole was made? Bone answered that question in its own slow way. If someone survived, the sharp, fresh edge of the opening did not stay sharp. Over time, the body rounded it, smoothed it, and laid down new bone along the rim. That remodeling turned a moment of violence or care into a timeline written in the skull. Under close examination, partial healing looked like a border that started to soften, but still kept sections of raw, cut edge. Tiny bridges of new bone appeared, uneven and thin, as if the body had begun repairs but ran out of time. That pattern pointed to survival, measured in days or weeks. Complete healing looked different. The rim became thick and polished, sometimes with clear regrowth that narrowed the opening. That took months or years. This detail changed the story. Many trepanned skulls did not show the clean, unchanged edge of a fatal operation. They showed remodeling, sometimes slight, sometimes extensive, proving that people got up, healed, and carried on. In some cases, the bone growth looked so mature that it could not have formed quickly. The new development became hard to ignore. A large number of individuals survived long after the hole was made, not just for a brief recovery, but for weeks, months, and sometimes years. Survival after trepanation meant more than a steady hand during the cut. It meant bleeding got controlled before shock set in. A scalp and skull carried blood, and even a small mistake could have ended fast. So when bones showed healing, the first implication was simple. Someone managed the immediate crisis. Pressure got relieved without the person bleeding out. Then came the slower danger, infection. A hole through bone created a doorway for bacteria, and swelling or fever could have killed days later. So survival suggested wounds got cleaned, covered, and watched. Pain also had to get handled, because a patient in agony moved, tore bandages, and stopped resting. Care had to continue after the cutting ended. That pushed the story beyond the dramatic moment of drilling. If someone lived weeks or years, recovery had required food, water, and protection while they healed. Work paused, others stepped in, and the patient stayed close enough to be monitored. Trepanation survivors pointed to organized aftercare. People who returned checked the wound and kept the injured alive through the long part. Trepanation did not stay in one corner of the ancient world. It appeared again and again in places separated by oceans and centuries. That spread forced a bigger question. Why did so many communities arrive at the same dangerous idea? The holes looked deliberate, but the reasons did not line up neatly. In some skulls, the opening sat beside a healed fracture, as if someone tried to ease swelling after a blow. Other cases pointed somewhere else. Some openings appeared on heads with no clear injury at all, which pushed archaeologists toward explanations beyond emergency care. In certain burials, trepanation seemed tied to social meaning, not just survival, something done as a ritual act or as a mark of identity and belief. The same action, cutting into the skull, could have carried a medical purpose in one community and a spiritual one in another. Then there were skulls that hinted at invisible suffering. Without soft tissue, seizures and crushing headaches left no signature on bone, yet trepanation still appeared as a response. The pattern suggested an attempt to treat symptoms people could see and fear: sudden convulsions, confusion, pain that did not stop. By this point, one conclusion held. There was no single explanation for trepanation, only different intentions, case by case, culture by culture. Some skulls carried a detail that changed the whole picture. Not just one opening, but two. Sometimes the holes sat close together. Sometimes they appeared on different parts of the same cranium. The edges told the story. One opening showed clear healing, while another looked newer, with little or no bone response. That pattern suggested a second attempt, made after the first one. In other cases, the same opening looked reworked. The margins showed one phase of healing, then fresh cut marks cutting into that healed bone. That meant the person survived long enough for the first wound to begin closing, then returned for more. And that raised a hard question. People did not volunteer for a repeat operation unless someone believed it helped, or at least felt it was worth the risk. Repeat trepanation also said something about the practitioners. A second opening implied planning, steadier hands, and confidence that the patient could live through it again. It also implied a community that accepted the danger and supported recovery twice. The bones suggested outcomes, not intentions, but the message stayed blunt. Some patients survived, improved, and came back. Trepanation became a procedure, not a one-time gamble. Trepanation stopped being only a mystery read from bone. In the first written medical traditions, surgeons and writers described skull opening as something a trained person could choose, plan, and repeat. That changed everything. A hole in a skull no longer stood alone as evidence of an event. It matched a procedure with a name, a purpose, and steps that could be taught. These texts laid out practical reasons for cutting into the head. A fractured skull could trap blood beneath bone. Swelling could build pressure the body could not release. Some authors described warning signs after injury and treated the skull like a barrier that sometimes had to be breached. They also listed tools for the job: borers, scrapers, and saws, built to remove bone without tearing deeper tissue. Now, the written record and the skeletons started to speak to each other. The round openings seen in graves matched the sizes and shapes a surgeon could make with those instruments. Cut marks and scraped edges lined up with described methods. Most importantly, the decision to open the skull appeared as an accepted option, not a desperate guess. Trepanation became a documented operation with indications, risks, and intended outcomes. Skull opening stopped being a gamble when medicine changed the rules. In the 1800s, surgeons learned that infection, not bad luck, killed patients. Antisepsis and cleaner practice cut the danger of turning bone and skin into an open doorway for germs. Then anesthesia arrived. Pain no longer forced speed and roughness. It allowed planning, steadier hands, and time to stop bleeding before it stole a life. Once patients could survive the opening itself, doctors started asking different questions. They did not only chase relief from pressure or vague symptoms, they searched for causes inside the head. Early neuroscience and brain mapping linked specific injuries to speech, movement, and behavior. That connection changed the logic of operating. Surgeons aimed at a location, not a mystery. Survival odds rose, but so did expectations. Results now got measured. The act of making a hole also became standardized. Trepanation, with its many older methods, shifted into named procedures with repeatable steps. A craniotomy removed a controlled bone flap and later replaced it, protecting the brain after access. Burr holes created small, precise openings to drain blood or relieve pressure without a large window. Skull opening no longer meant simply opening the skull. It meant reaching a target and closing with intent. In the distant past, a hole in the skull happened in a world of guesses. People watched a loved one seize, collapse, or fade after a blow, and they acted with what they had: hands, stone, and shared experience. The outcome stayed uncertain, and survival depended on care afterward as much as the cut itself. Still, the aim sounded familiar. Something in the head felt trapped, and it needed release. In modern hospitals, that same problem got approached from the opposite direction. With measurement first, scans mapped bleeding, swelling, and fractures before a blade ever touched bone. A neurosurgical team planned the opening, monitored the brain, controlled bleeding, and worked in sterile conditions built to stop infection. The procedure stopped being a leap into the unknown. It became a calculated intervention, designed to lower pressure or remove the cause of symptoms. That was trepanation's legacy. Even when the name changed, evidence-based cranial surgery carried forward the core idea that opening the skull sometimes saved a life, and it tested that idea with outcomes, data, and training. Yet the older meanings never fully disappeared. At the fringes, mystical trepanation persisted, promised clarity or cure without proof, and revived the oldest tension of all: desperation pushing people toward a hole in the head.